Hi everyone, my clinical pattern was IT band syndrome, which is an overuse injury that causes pain in the lateral knee due to repeated knee flexion and extension, and it is common in runners and cyclists. As far as demographics go, it affects athletic individuals of all ages, but it's most common in long distance runners. And as far as gender goes, IT band syndrome does tend to affect women more compared to men. And we would also use the lower extremity functional scale and the numeric pain rating scale as outcome measures for this condition. So mechanism of injury, it occurs due to repeated knee flexion and extension, particularly in closed chain. So like I said, running, cycling, and it contributes to impingement forces acting on the distal IT band and causes inflammation. Pain behavior, it is nociceptive, so it is a localized sharp or burning sensation in the lateral knee. Pain can be referred up the length of the IT band, but that is more common in overweight or pregnant women. Aggravating factors include running, going downhill, increased stride length, or descending stairs. Easing factors include rest, NSAIDs, and ice. And the 24-hour pattern, there should be no pain at rest. Pain slowly does increase though as aggravating activity increases, especially running. Pain subsides after activity is finished and can be difficult to elicit during an exam if the tissues are not actively inflamed or irritated. And do note that pain does typically begin at a very consistent time point in the bout of aggravating activity. So 1 mile into a run, 4 miles into a run, or into a bout of cycling, things like that. Precautions and contraindications, really just don't perform any deep transverse friction massage over the inflamed IT band, which that makes sense. Physical exam. During your observation, you might see genu varum, genu valgum, genu recurvatum, just all things that will contribute to increased impingement forces on the IT band. Active movement testing should be within normal limits, but hip abduction and knee flexion could potentially be painful. Passive movement testing, again, should be within normal limits, but there could potentially be limited and painful hip adduction range of motion, especially if the affected limb has like a really tight TFL, but resisted testing, cut, abduction, and internal rotation could be strong and painful or painless. So obviously if there's painful cut, do not perform MMT. Accessory motion testing and neurodynamics should all be within normal limits. Special tests, you should see a positive Nobel's compression test, which the sensitivity, specificity, and likelihood ratios are unknown, and that should be taken into account when using this test for diagnostic purposes. But if you're matching over their inflamed area and you're reproducing their symptoms, you can feel fairly confident that it is IT band syndrome. And you would also see a positive Ober test. The sensitivity is 41%, specificity is 95%, but I don't know the likelihood ratios. Palpation, there should again be pain to palpation of the distal IT band, especially along the lateral femoral condyle. Potentially edema and crepitation, but it would have to be pretty severe and it would be very actively inflamed if there was edema. And you could note a prominent lateral femoral condyle, but that would be in very chronic cases. Differential diagnosis, this could be confused with biceps femoris tendinopathy, lateral collateral ligament injury, or meniscal injury. And diagnostic imaging isn't super common with this condition, but you could perform an MRI to rule out intra-articular pathologies, so that's good. Signs and symptoms indicating referral to physician. If there's increased pain with weight bearing or if there's a palpable nodule, especially if it changes size, you definitely need to refer to a physician to rule out malignancies like osteosarcoma and things like that. And then surgical indicators, there is rarely ever surgery performed for this condition. If there is, you could do a triangular resection of the IT band over the lateral femoral epicondyle, or a Z lengthening of the IT band, but like I said, they're not very common. So that is all I have.